Yeah, hi sir, it's 1 minute to go.
Just ask them whether can you hear.
Hello.
Yes, sir.
Yes, sir, we can hear you.
Am I audible?
Can you see me?
Yes, sir.
Thank
Sir,
you.
you're
Thank you for joining.
audible.
Hi, Dr.
Video
Reddy.
is not on.
Nishikant, at 2 o'clock will start.
Yeah,
When we
sir.
are live, just let us know.
Okay.
So, Santosh, Andar, please come. Ravi, come.
So,
Five,
Manish, just check
four,
the video.
3, 2, 1, start, sir.
We are live.
Yes, sir. We are live. So good afternoon, everyone. Myself, Dr. Nishikant. It gives me great pride and enthusiasm that we welcome today all of you for the Saturday School of Orthopedic, a live surgery workshop conducted under the aegis of Telangana Orthopedic Surgeon Association and Twin Cities Orthopedic Society and supported by the Alkem Laboratories. So through this initiative like workshop by Alkem, we reinforce our commitment to the empowering medical community to assess the cutting edge surgical education and real-time leading experiences for the doctors. So this unique event is being live streamed directly from the Apollo Hospital, Hyderabad, offering a great opportunity to observe and learn the advanced orthopedic surgeries performed by some of the most respected names in our field. Also, it gives me great pleasure to share that the workshop have a 4,562 registration and have a participation from almost 35 orthopedic centers, reflecting our strong enthusiasm and commitment for the surgical excellence across the community. So today we will have a two session, two robotic. First surgery will be the robotic knee replacement surgery by Dr. KJ Reddy and team. And second surgery will be the proximal femoral neck fixation by Dr. Shiva Reddy and Dr. Jairam Reddy. We also have a two session for ACL reconstruction by Dr. Ravi Teja Rudraraju and MPFL reconstruction by Dr. Sridhar Reddy. So this surgery format will have a powerful platform for the learning of the real-time surgeries and in clinical depth of the two sessions for ACL reconstruction and MPFL reconstruction. So let's look forward for the highly interactive and inspiring learning experience. So the first session will be by Dr. KJ Reddy. So sir is a chief joint replacement surgeon at Apollo Hospital, Hyderabad, India. Sir has a special expertise in robotic joint replacement surgery. Also have a expertise in a knee sports medicine and arthroscopy knee surgeries. Doctors have received various awards like Best Orthopedic Surgeon Award by the Times of India. Then Pharma Asia GCC Award for Excellence and Leadership in 2021, also awarded as a Distinguished Clinician Award from Apollo Clinical Award at 2023, Icon of Indian Healthcare Doctor Excellence Award at 2024. Sir also held esteemed positions at a consultant and head lower limb unit at UK from 1999 to 2003. Sir is also the chairman at a fellowship committee at Indian Orthopedic Association. Sir has also held the position of President Telangana Orthopedic Surgeon Association from 2016 to 2017. Also, sir was the president of Indian Orthopedic Association from 2015 to 16. Also also held the position of secretary of Indian Orthopedic Association from 2014 to 15. And sir has a various publication and also done the various research and published many articles at national and international journals. So welcome, sir.
Thank you. Thank you very much, Nishikant, for your kind introduction.
Yes.
And I would like to thank Dr. D.D. Shaw. I think his dress code has changed today. And my good friend, Gal Chandrasekhar and Madan. Thank you very much, Madan, for the last minute participation. And we won't take much time. It is a wonderful to see all of you. And thank you very much for Alchem to do this again with the various centers. We are going to, as Nishikant said, we will have 2 live surgeries. And in between, we will have video as well as lectures. So welcome all the audience joined physically as well as online. We will have exciting program. And you can have physical questions as well as digital. There is a chat box. You can put your question on the chat box. We will be able to answer in between. During entire surgery, you can ask anytime. We will try to answer the question and we will have an excellent discussion. Now, I would like to invite our senior most surgeon, Dr. Jairam Pingale, who established the department in Apollo, Hyderabad. He is the first one to do knee replacement in this Telugu states. And I'm very fortunate to work with him and the entire team. Dr. Jairam Pingale, please, sir.
Thank you very much, KJ. And congratulations to the entire team for the excellent program that has been arranged here. And I'm sure this will give a lot of insight to many of our youngsters and all other surgeons combined to do this type of surgery and improve ourselves. Thank you very much. Thank you.
So our backbone, Dr. Ravindra Babu is here, medical director, TMS, Director of Medical Services about region AP Telangana.
So first of all, let me thank all the delegates.
Yes.
Yeah.
Yeah. Okay, good. Thank you.
On behalf of Apollo, thank each one of you. I think we have a faculty from all over the country, senior experts who are working on the robots and then wanting to share their knowledge to the juniors and the other surgeons who would want interested in this particular area. I'm standing beside Dr. Jairam. Actually, he is the one who's been the backbone. He's the bone for us, actually. Started this hospital. And now Dr. KJ Reddy, he is now the pioneer and, taking this robotic surgeries to the next level, doing the most complex revisions and robotic surgeries. Very proud of you, sir. And then the orthopedic surgery at Jubilee is doing a great job. I wish all the success and we will do many more programs like this. Thank you so much.
Thank you very much, Ravi. Wonderful to have your support and we've been doing so many programs. I think, thank you once again for all help. Now our dynamic COO, Chief Operating Officer, Harkaran Singh is here. He will say few words.
Namaste everyone and thank you so much. I would like to thank Dr. KJ Reddy, Dr. Pingle for creating such big platform for the entire nation where we can actually come and showcase our expertise and all the students, all the faculties across, even the surgeons, they can learn and they can have live questions. They can ask those questions and clarify their doubts. It's a great opportunity and for creating such big platform for each and every one. And I really want to thank and congratulate the entire team for making this possible. And thank you so much, Dr. KJ Reddy. Thank you so much, Pingle sir, for your support. Thank you.
Thank you, Harkaran. I think things will change in future. I think with the dynamic of Ravindra, great combination of our administrators. Sunita, also our nursing director, she is a great lady, very knowledgeable. Her husband is a neurosurgeon and she joined our team in Apollo, Jubilee Hills.
Thank you, sir. Thank you. I think this is a great opportunity for all of us to be here. And, it's a great learning for all the students who want to ensure that, they grow in their career. And none other than, I think, two great people who are standing here. Pingle sir, thank you so much. I think it is really great.
Dr. Kaushik is here, the Varun is here. I saw Varun.
Yeah.
The team, and the department is here.
So,
Department.
KJ sir also, and the entire orthopedic department. I think it's a great opportunity, and all the best to all of you, and thank you so much.
Thank you very much. I think we will have the inaugural, official inauguration. Probably they can play the video, audio. Aravind. Video, audio.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you very much. Thank you, everybody. We're going to start. Thank you. Wonderful to see all of you. Thank you. So we will have the patient details next. Then we'll have the, thank you all. Planning. Thank you. Thank you, Ravi. Thank you. Harkaran. Thank you, Jaram. Kaushik. We will have the patient details, clinical details, followed by the planning for robotic surgery. So we will play the video, we pre-recorded the video of the patient details. Can you have the video, please? Go inside. Good afternoon. We are going to demonstrate robotic knee replacements on helmet on. This lady who is 65 years old, on the left side, as you can see, she got a severe osteoarthritis both sides. We did this right side yesterday, and you plan to do on the left side. And as you can see, there is a severe medial osteoarthritis as well as patellofemoral osteoarthritis with osteophytes. So we're going to discuss about the planning and intraoperative execution of the plan. The biggest advantage of a CT-based robo is we can assess the deformity, the alignment, and the amount of wear. We can plan it and execute exactly what we planned with the feedback system. So we're going to demonstrate the robotic knee replacement on this lead.
Okay. Planning, please.
Can you have the planning screen, please? We will use CT-based robo. This is a QS robo. As you know, there are imageless and image-based robos. Now we're going to use the. Can you just adjust my mic? I think this is. This is a CT-based QS robo. So we take the preoperative, as you can see, to decide what is the mechanical axis and what is the deformity, as you can see on the video. And this is the center of the head, center of the femoral condyle, as you can see, epicondylar line. Then you go to, that's a medial epicondyle identification. This is a lateral epicondyle. Medial epicondyle will go to the sulcus. Sulcus of the medial epicondyle. Then we go to the lateral posterior condyle. As you can see, the line is drawn. Can I have the salient? And medial distal condyle. And we put the implant and check the size of the femur first, whether any notching or whether we're taking too much of posterior condyles. As you can see, my mic, I think, is rolling off. Can you put a sticker for that? As you can see, that looks good. The femoral component, there is no anterior notching, and posterior also offset. I think we are happy with the amount of the bone we are resecting. As you can see, you can rotate around the 3D picture where you can rotate around and see all the lines are appropriate. So this is the preoperative, and we are going to execute same intraoperatively. That's the biggest advantage. So now you can see the resection, depth of the resection, and the distal medial side 8.7, distal lateral is 8.8, posterior is 9.8, posterior lateral is 9, and all other readings as you can see on the side. Can I have you? Yeah. Now, this is the registration. There is a initially, I think it's now. Initially, we will have the gross registration, then registration points on the femoral condyles, anterior cortex, as you can see. And of course, after the femur, we see the proximal center for the tibia. Ankle center of the ankle is taken. Then tibial tuberosity is identified. PCL fossa center is important for the axis, tibial axis. And a medial condylar center. Lateral condylar center, as you can see. Posterior slope is decided, and what is the, this is pre-operatively, because everything going to change intraoperatively. We will change according to, we can see the on the left bottom one, when we change the slope, it is changing the size of the gap. Then tibia also, we have the, you can see the proximal tibia. Medial side, we are resecting 1.6 millimeter. Proximal lateral side is 6 millimeters. That's a posterior slope is 4 degrees. Internal varus is 0, 0. Okay, so this is what we are accepting. And registration, gross registration on the medial lateral. I'll show you this in detail when we're doing the registration. Also proximal lateral, proximal medial. Then there comes axis. This is important. So the preoperative on the right side is the existing one. We want to achieve the one on the lateral side. That's what we are aiming for by doing all these adjustments. So we want to achieve this one. So we know beforehand what we want to achieve. And we will see whether we are going to execute the same. Okay, now we will start up surgery. Can I have the cover, please? Yes, I think as you know, just a minute. I'm just getting ready. Okay, one. Okay, good. Very good. Thank you. So as you know, there are imageless and robots as well as image CT guided robotic one. We have presently we're going to use the image based robot, that is a QS one. It's a Indian based company owned from Korea. As you know, in all surgeries, draping is the most important part. Unless you have appropriate position, I think you struggle throughout the operation. Can I come in? Got this one. So this robot, as you can see, can you see the screen? So we have a camera. Show the camera. Oh. Camera, connect. If you connect it, yes. And we have a screen, not switched on yet. And we have the fully automatic robot, which is being draped. As you can see the position, I think one camera from here, other camera from here. So position is important because we use the leg holder. As you can see, you can put any position and it's both flexion, extension, leg. Yahan dikhana. Niche or I can't. Yeah. Can you have two cameras on the... Dr. Shah, can you see both? Yeah, so we can pull extension and you can go up to any amount of flexion and both internal external rotation you can do.
It's seen very clearly, sir.
You can see?
Yes, sir.
Okay, thank you. Can we have the table little low to start with? And that's a monitor I wanted to show you. Can you show the monitor as well as the camera? As you can see, one camera can that's again. You stay here. You don't move. तुम इधर ही रहना, ठीक है? We'll change this one. यहाँ से दिखाना. Come see. You come. See there. Come this side. Marking pen. So that is the monitor, and that's the camera. So we have robo unit as well as the monitor and camera. Can we have the camera again onto the leg? Little close up. Can you see this one? Close up. Dikh raha? Okay. So we are going to pass the pins for the markers arrays. We will pass one to the onto the tibia, one onto the femur. So the positioning from the tibia is about 4 fingers, maybe 6 fingers around this area. Can I have my second gloves? Right. I think as we go on, you can probably keep asking questions or discussion.
Yeah.
Around this area, I'll have the guide, please.
Sir, if you allowed, we can take 1 or 2 questions related to this surgery that we have received during the registration.
Yeah, sure. So we're going to pass that one. That's a guide. So put the guide there. Knife, please. I'm going to pass the...
Sir, if you allowed, can we take some question related to the surgery during the session?
Sure, you can go on. Whatever question you can ask, there's no problem at all.
Okay. So, sir, Dr. Amit Vivedi from Ghaziabad asked the question, what is the preferred modality for the TKR in extra-articular deformity of tibia? Robotic TKR or conventional TKR?
Robotic TKR, there's no doubt about it. Or navigation at least. Can I have the drill again? Those are the, so we put the arrays so that the position generally onto the medial side so that the camera can see when you put the arrays. And then we'll pass on the femur as well. About same 6 fingers. Somewhere there. Guide, please. Okay. Knife. Can you show the top से ऊपर से दिखाना इधर. Okay, open it. Okay. Put it. Make sure you are in the center of the femur. Otherwise, wait. Yes,
sir,
go on.
So the second question, Dr. Yogit Sai asked, up to what of cut for tibia or femur can be done in robotic TKR? Does it vary with different companies? So maybe sir.
Yes, I think cuts based on the wear as well as the deformity to some extent. We are going as we go on. As we go on, the great thing about robotic surgery we change. No? Okay, tunica. The great thing about robotic surgery is, see, as we know, the deformities are at the bone. Most of the knees, as you know, the soft tissues or ligaments probably not affected that badly. It's most of the deformities, correctable deformities are at the bony level. So the great thing about robotic surgery is we correct the deformities at the bony level. So we do not release soft tissues. Yashmak, we do not release soft tissues for flexible or correctable deformities. We only release if you feel it's a fixed deformity. So I think based on the deformities, every time it varies. There's no fixed amount of tibial or femoral cut.
Yes, sir. Dr. H.S. Gill or Dr. Dilip Shah, if you want to add something.
Yeah, go on.
It's Dr. Madan here.
Yes.
So just on the point of what Sir was mentioning on the about the tibia cut, how much of there was a question on that. So with the robotic advantages, it's mostly a bony correction than the soft tissue. So we don't release the soft tissue that much. I agree with that. And another advantage of this robotic is we can have a varus cut or valgus cut and cut the tibia medially and laterally in a different MMs as well. So that is the main advantage of robotic. That's one point. And the previous question was extra-articular deformity. What is the best? There was a question about. Because in a conventional one, so we use the intramedullary rod, but the deformity is more, then we can't use the intramedullary rod. So that is a disadvantage of that. So in that case, robotic will be the best thing to do. So that's my point to add on that.
Yeah, absolutely. So I think that's what we learned from robotic surgery. We correct the deformities at the bony level. Flex up, that is correctable deformities. Knife, please. So it's a standard.
Sorry, Dr. Reddy, are we going for mechanical alignment or kinematic alignment with this?
Yeah, that's a big question. In between, midway.
Robotic is mostly kinematic alignment.
Yes, kinematic, but we see
robotics.
Our CT scan, everything is, we are taking about mechanical, isn't it? So in between, there is a lot of debate about which axis. People are saying about so many axes. So I think end of the day, it's in between. So,
sir, one more interesting question asked by Dr. Nadeem Khan from Udaipur. Elaborate the effectiveness of intraoperative periarticular cocktail injection for the pain control after the knee replacement.
Yes, very much. That's a routine.
Okay.
We do under spinal, femoral block, and postoperative femoral block. Of course, periarticular injection also do. We'll demonstrate very over the course of the. So that's the. That's all, as you can see, medial parapetalar incision.
One broad question asked by Dr. Sahil Shah. What are the advantages of using robotics for the total knee replacement? We, our panelist, can answer this.
Sorry, what was the question?
What are the advantages of using robotics for a total knee replacement?
Yes, I think
conventional.
even we had our doubts for a very long time. But once I started using for the last few years, I think there are clear advantages that we know what we are doing with the haptic feedback. So we can, I think probably we keep saying it's less stressful to the surgeon, probably less soft tissue release, as you can see, because I'm not just exposure only. I'm not going to release here. Just take that. So we know, see, probably with conventional, we plan, we execute, but we are not sure what we are doing, whether going to get correct alignment or not. But here we are sure that what our alignment is. So I think there is a clear advantage. So I think I've just exposed it. As you can see, now no release. And we're not taking the osteophytes now because the CT scan, everything readings based on osteophytes. So we keep the osteophytes. Once we have the registration, then balancing, I'll take the osteophytes. Okay. Put the trackers on.
Adding to the advantage of robotic or non-robotic is, as Dr. Reddy was saying, the minimal dissection of the soft tissue. So you don't release it too much. The pain-wise, it's better option. And bleeding is less also. And pre-op planning is there. So we know that where the implant comes and bony cuts. So deformity correction is for precise. So we can go up to 0.5 millimeter also with precision on that. The precision is the another thing which can't. Then human error can be minimized. So those are the big advantage of robotics.
Yes, I think, see, as a surgeon, if we know what we are doing with a feedback system, we feel very comfortable because we don't know what is achievement intraoperatively. If we can have a feedback, if we know what exactly our result is, I think we'll feel comfortable. I think for the patient also, because we keep saying alignment is important. So we are sure of getting a good alignment in majority of the knees. And of course, I must say for all the audience, whatever best technology we use and whatever best centers we are doing surgeries, still about 19% of the patients are not happy with our total knee replacement. So probably our aim is to reduce that number of unhappy patients. Okay, now the arrays are on. So we start registration.
Sir, Dr. Rakesh Rajput want to add something for this question.
Yeah,
Yes, sir. Over to you, sir. Dr. Rakesh, sir.
So can you make sure you see?
Can you see? Can I add the advantage of robotics to that?
Yeah, sir. Yes, sir. Yeah.
Yeah, I think that if you want to break it down, the first part of robotic is navigation. You know, like you use your navigation.
Hi,
in your car.
Rajput. Hi,
Hello,
Rakesh. How are you?
Dr. Reddy. Yeah.
Go on.
Very nice. You carry on. I'll just explain few bits.
Yeah,
for robotics.
I think I'll just show you the. Can we?
Okay.
That is online. That's online.
Yeah. Yeah, sir. Yes, sir.
Can we see? Can we see the screen on the? Can you see the screen as well? Our own camera can go to the screen. Huh?
We cannot see the monitor screen, sir.
See, keep this one and screen, because screen be connected to the directly online, whether you can see it or not.
Okay.
We can see the screen now.
Screen and display, yes, okay. So now that's the medial one. Okay. Lateral, yes. Anterior. Medial crest, yes. Lateral crest. Yes, medial condyle, lateral condyle. As you can see, we should get a value which is less than 10. We got 6. Can you see that? Rakesh? Yeah.
Yeah, visible.
Yeah. So now the registration of medial condyle, yes. is, 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 is. Now the lateral condyle. Is, 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 is. Too close, okay. Is, 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 is. There's an osteophyte here, probably difficult, but we'll see. Is, 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 not got it. Is, okay. Is, is,
Mr. Reddy, sir, you should be good at playing video games, isn't it? It's a good thing to
yes,
play on.
it is. Yes, you're right. Yes. It is important. That's, I think, your 3D coordination. Yes. 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 So the value is 1.3 is okay. Wow. So up to 1.4 we can take it. So 1.3 is, I think, generally it should be around 1, but that's because of the osteophytes. Can you see so much of osteophytes? The value, we can accept a little more value than 1. Okay. Yes. Yes. Just rechecking that we are, bony movement is not there, and registration was on the right bony marks. Okay. Now, so that's a femur is done. Now we go to the tibia. See, previous navigations, the biggest problem was registration was a big problem, but with especially with robotics, registration doesn't take much time. Yes. 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 No. Go back again. There is an osteophyte. Yes. Yeah, lateral condyle again. Yes. Tibia, tibial tubercle, yes. Medial side, yes. Lateral side. Okay. So that's why less than 10 is acceptable. So 5.22. Okay. Yes. 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 Okay. No, take go. S. 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 Gone. S. 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 Too close. Yes. Wait, let me do it again. S. Okay. So here I can see this. We're not released any soft tissue at all. We'll see. Yes. 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 Okay, go back. Go back again. I want to take it more. Yes. 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 Okay, yes. 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 Oh, take it again. Osteophyte, that is. Yes. 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 Take it. Yes. 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 Okay. Yes. Yeah. Yes. 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 So that's 0.84. Not many osteophytes. So this is ideal one. So we got 0.84, which is very much acceptable. We'll take the check again. Yes. 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 No. Take it in. Which in the, okay, yes. So now we got all the reference points. Now we'll see what is the deformities, and we'll take the osteophytes before that. This is outside this. The femur, Shiva, femur tissue. Ravi leader. Okay. Ravi, scrub. Ravi, scrub. So we take the osteophytes now. So after registration, you take the osteophytes and see what is the deformity and how we're going to correct. Ravi, you want to get scrubbed? Huh?
Yeah, sir. Meanwhile, Dr. Rakesh can answer the question.
Yeah.
So, Rakesh, sir, over to you, sir. Rakesh, sir. Yeah.
Nishikant, is the same question you want me to answer?
Yes, sir. Yes, sir.
Advantage of robotics? Yeah, it's a very common question, and I think we need to answer that to our patients also. So generally, what we explain is that like you drive in a car, now every car is driven by GPS. So first part of your robotics is actually the navigation. Like you just saw Dr. Reddy doing all the points. This is actually extrapolating your CT scan now to your actual distal femur and proximal tibia. So that is your navigating it now. The second part of it is like once you've done all that, you just saw some figures which came up like a 9.8 or 10 or whatever. In different robots, is a different screen. So
yeah.
this is what we call as start doing a virtual surgery. Like you do a virtual surgery before you actually start executing one, so that you don't make mistake with the patient. You do all the mistakes beforehand, and you can extrapolate and all that.
Yeah.
So number three, what you sorry?
Yeah. Go on.
Go on, Reddy.
Go on.
Okay, so you want me to carry on. So the third part is now the part of the robo is actually, that you don't want to release. When we say we don't want to release tissues, like for a varus knee, we don't want to go beyond the deep MCL. So all the posterior structures and complete MCL, you want to keep the envelope intact.
We will demonstrate that one in a minute.
Yeah. I'm just carrying all the things
when you're planning, yeah, you're right, absolutely right, Rakesh, because we plan in a way, because robo, if you have a safe margins, within safe margins, you cut it so that the important structures are not involved in the resection. So as you can see, can you see the screen now? So that is full extension without any correction. You can see there is 9 degrees of flexion and 9 degrees of varus. We'll just find out how much is correctable. So I can correct up to 4 degrees varus and 3 degrees flexion. That's in full extension. If you go to 90 degrees, there is limb varus 3 degrees, not much. So we can probably correct up to 2 degrees. Okay. Yeah. So now we can say that's interesting, very interesting. You have the values of actual captured and of course the maximum, but that's too much. 15 millimeters too much. So we'll go up on the tibia. Tibia, how much you're cutting? So reduce the tibial cut. You can play around now with the tibia, with the femur, and get your gaps right. One more. Generally, we try to get 9, all 9s. so that we can get a 9mm insert. Go on.
So, Nishikant, this is what I was saying, that you're doing a virtual surgery right now.
Yeah.
Huh? So TB, how much you're cutting? 0.4, 0.44, 0.5. So, okay, can we, so that TB, I think you can see on the medial side. Can we reduce the distal femur? How much we're taking distal femur? 9. Reduce it. Go down. Come down. Yeah. So now we got medial side 9, but lateral side is laxity is there. So can we? So 9. Oh, what? So we got 9 and 12. If you want to, can we reduce lateral side? Lateral side 2mm laxity is acceptable. Can we just do little varus on the tibia? Maybe 11 would be ideal. Yes, that's ideal. I think, as you can see, we got 9 on the medial side, 9 on the medial side. On the lateral side, we got 11 and 10, which is acceptable. Okay, now we can. Yeah. So 9, 10, maximum is 10, but all 9 and 8. So that is acceptable. So the advantage of, as Rakesh said, we can play with the robo, these parameters, and we can get what we want, which is not possible with conventional surgery. So this is what we're going to resect, and we'll see what would be the result. What is it? So now you can see flexion is almost less, and varus, how much we corrected? 3 degrees varus. We will see, and after resection, slope is about 4 degrees. Rotation is 0. Okay. Pin, please. We used to use 2 pins. Now we are using only 1 pin. Okay, pin there. And it's all Rakesh and Dr. Shah, Madan, and Chandrasekhar. It's always important to have good team. And we have excellent team. These people are my students. They did under me, and now they're my colleagues. Very soon they're going to be my bosses. Dr. Shiva Reddy is the senior most. Can you show? Say hello to camera. This is Dr. Shiva Reddy. This is Dr. Ravi Teja. He's expert in robotics. He traveled around world and worked with all types of robots. So he gives me knowledge every time. Every time I do, I learn something new from him. Dr. Ravi Teja, sports and knee specialist, robotic knee replacement specialist. And Dr. Sridhar, he was my student from NIMS. He's done fellowship in orthoplasty and joined me. And of course, Yashwant is there. And Lakshmi is putting other way. She is working. Most important part, as I think for the young surgeons, your OT staff is very, very important. She is working with me for the last 20 years. And Renika, Mini, and Dr. Nandu. Where is Dr. Nandu? Yes, he is here. He is our chief anesthetist here. Hello to our team. Okay. And of Abdul, our technician. Come, please attach. So now we get the robo attached to the patient. Okay, yes, okay, go on. Come. Dr. Rukmini is there, our anesthetic colleague. Go on. So as you can see on the screen, now we have to center. Those circles should be within that circle. Stand, okay. Up on the table. These are the technical details, probably difficult to experience on that one, but once you see physically, you understand it's not that complicated. Up, up.
Okay. Sir, can we take one more question?
Yeah, go on.
Yes,
We just attach the robo, then we'll see. Just see this one.
Okay.
Gone, little more up. So now we position the robo in our within readings, within that green. Everything should be green. That's important. For a, what is that? Layman like me only see green. If anything is red, then that you have to adjust the readings accordingly, position accordingly. So we attach. Wait. Okay. No. Yes, gone. We bought Brain Lab in 2009 and we struggled for quite some time because the registration was difficult and hanging, freezing screen. So we gave up. But as you can see, registration takes hardly 4-5 minutes with the latest robos. Okay, go on. Probe to me. We recheck the position of the robo and the leg so that position is marked. Okay. And check the bony landmarks again. Make sure you not moved too much. Yes, within one. Okay. Gone. Lateral. Yes. Okay. So that's, I think, we attached the advantage of this one. Now I can go have a coffee or get other case done in another OT and come back by the time robo finishes. It takes about 9 minutes, 10 minutes. Huh?
Sir, yeah, sir. Sir, Arpreet Gill, sir, we will take 1 or 2 questions.
Yeah, go on. Now we can take questions.
Yeah. What's the role of templating before such kind of surgery? And also the role of physiotherapy before the surgery?
Go on. Go, move back, camera. Can you repeat the question again?
What's the role of templating before such kind of surgery? Also the role of physiotherapy before the surgery?
Yeah. The second question, physiotherapy is very, very important. People keep saying that we do the knee replacement and you don't need physiotherapy. I don't believe that. And probably it's not true. Because physiotherapy is a key role and the advantage of doing a robotic. The advantage of doing a robotic surgery is we do minimal soft tissue. As you can see, I have not released anything, just exposed. So there is no soft tissue release. The recovery is faster, pain is less. So that we can make them stand, a single one, make them stand on the same evening. That gives a lot of confidence to the patients because they can say, I stood and took a step on the same day. That gives a lot of confidence for them. And the first question, Nishikant, I didn't understand. First question.
Role of templating, like X-ray.
Templating. See, yeah. That's what we were templating. The first part I showed was templating with a CT scan.
Okay.
Templating with the X-rays would be difficult. This is a CT scan with the software. So we template, we plan, but we have to change in the intraoperatively. So templating is very important. CT scan, we templated, fed into the robo. Rakesh, you want to add anything?
Yeah, I think in general, templating with knee, the typical slides, it's actually gone out of the window. But there are 2 incidences where you need to worry about them. One, post-trauma, because the parameters are not same. Then you might want to know whether you need offset stems or not. So that can help you with templating. So you can order offset stems. And number 2 is when you see a very short stature and sometimes a very large person, like in North India, you do come across people who are beyond the larger size you have. So in that case, you have to be either looking for where you can get it or, customize your implant. You have to manufacture it. So those are the 2 areas where I think you need to be worrying about. Otherwise, in general, for knee, template is not very useful. Yeah. For hip, it is very useful, but not for knee.
And as you can see, that yellow line on the screen, that is safety. We cut within that yellow line, safe zone. If it goes outside the yellow line, robo will stop. And especially when you're cutting the tibia posteriorly, femur posterior condyles, we protect because the initial saw-based robo sometimes can be difficult. If you're not being careful, you can push and cut the vessels. There are incidences, even with burr-based robo cutting the popliteal vein. So it is important that margin, when we finish the cut, we saw there is a rim of bone behind tibia and femur as a safety margin. And that will cut within that safe zone. And as you can see, I think I also, to some extent, believe that burr cutting is more precise than saw cutting. Of course, equally, both are equally good. Because burr, what happens is most of the machinery, most of the refined instruments are cut with the burr. Even our joints are what is polished with the burr. So burr is more precise in making the cuts rather than the saw, but I think saw also equally good. We can get up to 0.1 millimeters difference. And while we are cutting, you can see how much you are cutting each depth. You can see on the screen itself, medial side, how much you are cutting, lateral side. Every time it is indicating us so that you are within your limits, which you have decided on your planning. This is the anterior cut. We made sure that there is no notching when we size the implant for the anterior cut.
Can we have the camera on the
robo?
knee?
Me. On the knee, yes. Can you see the knee? Robo cutting the knee? Yes. Can you? This side, come this side. Put in the rope. Onto the rope. Can you just take the little this one? Yeah, go on. Now can you see?
Yes.
Nishikant, yes.
Yeah.
Yes, sir.
Yes, Dr. Reddy.
Yeah, sir. Dr. Harpreet, you want to add something?
Yeah, go on.
Already Dr. Reddy has told about the advantages of burring versus saw. So there are various these robotics. One is the saw and the other one is this burring type. So what do you feel, Dr. Reddy? You have experience with this burr. Have you any experience with the saw?
Yes, we have willies as well. We have a saw based. I think it all depends how you use to do it. I think there is no superiority of one on the other. I think both are equally good, provided you know how to use them. I'm more familiar, we do more number of cases with burr, so I think I find comfortable. But depends upon the burr with we can use that company implants. People nowadays demand, I want Johnson & Johnson, I want some other company. So we have to use the robo according to patient wish as well.
I think the burr would be beneficial in the sclerotic bone as compared to saw, though I don't have any experience with this, but this is what the feeling I have, that probably saw can skive off, but this burring is going to be very accurate.
Yeah, probably, yes. See, whenever that burr goes red means it's a hard bone. When it blinks as a red, that means it's quite hard. And as you can see how the robo goes around the corners, avoiding the soft tissues. And it's, I think, very clever, very innovative, very clever. Automatic robo, it goes around, doesn't go nearby patellar tendon so that it won't damage. But even then, of course, we had to protect it. Light on the Can you see better? No. Okay, good. Okay. Now we are up to the posterior condyles. And as you can see, how much we are cutting the posterior condyles as well. And this is very interesting part. The log holes, it's very precise how it cuts the log holes, and the rotation of the femoral component is maintained with this log holes.
Dr. Reddy, I have a question for you.
Go on.
Hello.
Yeah. Yes,
Go
sir.
on.
Yes, sir.
Audio is not. Audio is.
I think you are muted. Now you're okay. I can see. Yeah, go on.
Yeah. What do you say about the kinematic versus mechanical? How do you choose your patient, whether you want to do mechanical alignment or a kinematic alignment in a patient?
I think what we see, there's a lot of discussion about it, mechanical, kinematic, but this is, I think, to some extent, a native knee. We want to get back the natural axis of the knee. Ravi, you want to elaborate on that one? Can I have it? Yeah, go on. Probably Ravi can explain better. Mike, please. That's important question. Wherever we go, meetings and these discussions. Other day, someone was saying there are 9 different axes. But I think it is end of the day, we have to get to the native axis of the finger. Go on. Go on.
Yeah, that's a very interesting question, actually. I think I'm sure most of the viewers have. Can you hear me?
Yes, sir.
Yeah. So there was a paper that came out in 2021 from Sydney, from Sam McDessie, talking about CPAC and different knee types. I think before we talk about any kinematic or restricted mechanical, whatever the alignment philosophy that we would like to choose, I think as KJ sir was mentioning, the logic behind was that we want to restore the native knee type. Say, for example, if a patient has got a varus knee and is suffering from that kind of knee for some time, and now we are putting him into dead straight, like using the mechanical alignment, it was thought so that some people are dissatisfied, and that could be one of the reasons. So now if you choose to do with the kinematic approach, you can most likely restore the native knee type, which is a varus knee in most of our Indian knee types. So it doesn't matter which kind of approach that you would like to choose. It can be inverse kinematics, it can be kinematic, or it can be anything. But the concept is that you want to restore the native knee type. So that's the main essence of choosing the right kinematic or any alignment philosophy that matters.
That's the key point. So it is to some extent personalized knee. So we restore the natural knee, native knee of that particular patient. So that's what we are hoping to do. Okay, femur done. Tibia, register. Go on.
What about the CR or PS? What do you prefer, Dr. Reddy?
I think I've been doing PS for a very long time, and a lot of discussions about whether which is superior, which is inferior. Both are 2 different operations, I believe, and both are equally good. See, majority, 99% of the time I do PS because I have only 2 ligaments to balance. Becomes very comfortable. And some of the papers say PS knee has got better range of movements. Very small knees, rheumatoid arthritis, I do retaining. Otherwise, routinely I do PS knee. And there is not, I think there is not much of difference whether you do PS or CR knee, because it is they're 2 different surgeries.
Yeah. Okay. Yeah.
Okay, now we finished the femur. Now doing the tibia. And here you can see the safe zone is quite anterior. We intentionally put the implant anteriorized, so that the posterior rim is kept well and it doesn't injure the vessels posteriorly. Because tibia is very important part where if it goes beyond the posterior border, then it might damage the vessels. Okay. You're right, I think this is quite hard bone, so we're changing the burr in between. Okay, gone. Who's gonna sit? Nandu, taken case other side. Huh? Okay, very good.
I'm Dr. Dilip Shah, and I just want to add the literature which says that kinematic is better in pain relief, and 2 years of follow-up study by a Secord journal paper.
That's true because we do not do any soft tissue release.
Right.
See, in the past 90s, we used to do extensively in London. I remember we used to snip the MCL, little knife put horizontally, and snip the MCL sometimes. But now, no soft tissue release. You see now, we have not released anything. And once we trial, we will know whether we need any soft tissue release at all. And that, I think, the pain, most of the pain comes from periosteal release, subperiosteal release. So if you're not releasing the tibia or on the femoral side, you
then
do
the
not get
pain
so much
component
of
will
pain.
not be there.
You're right, absolutely right, Dilip.
If I were to ask the anesthetists in the meantime, have they given only spinal, or they have coupled it with epidural also? And have they left any epidural catheter?
Just a minute, I think we finished. శివ నువ్వు పోతావు అక్కడ దానికి వెళ్తావా నువ్వు వెళ్ళు ఇద్దరు చెప్పారు ఓకే yes Dilip, you wanted to say something. You said something already.
Sir, unmute yourself, Dilip sir.
So now we finish the cuts. So
Dilip sir.
detach the robo.
Yeah, Dilip sir, unmute yourself.
T-wrench.
He was doing an important job, so I didn't want to trouble him. Now, if I can ask the anesthetist, is it coupled with epidural also, and is the...
No epidural. See, what happens is, we used to give epidural in the past very commonly, but it makes muscles weak, uncomfortable sensation. So we do not use epidurals. We use spinal and femoral block. Nowadays, we stopped using femoral pump as well. We use a single shot. And pain is very, very much controlled. Okay, can I have the homens, please? Okay. Now as you can see here, can I have the camera focus here? Can you see here? Light, I think probably. Light, little less light. Yeah, other one, little less light. See, that is as you can see, posterior condyle is not detached. Still there is a bone. Still there is a bone. So that is a safety margin. So I'm going to complete it with an osteotome. You have to be careful when you're levering out, but I think that's the big osteophyte as well as coming out. Take that one out. And as you can see here, there is rim here also. Rim is very well preserved so that it doesn't damage the soft tissues. Okay. Homens, straight homens. That. Meniscal grabber, yes. One more. Can we put on this camera onto the knee? So taking the remnants of the meniscus. Okay. Big swab. Okay, that's me. Taking the remnants of the meniscus here.
Yes, sir. One question from Dr. Rachit Shah from Pune, not related to the surgery.
Yeah.
How to manage a tibial avulsion of medial collateral ligament? It's an uncommon injury.
Tibial or femoral?
Tibial,
Generally,
sir.
it's a femur.
Yes, sir. Tibial avulsion.
Tibia.
Yes.
You should treat by preventing it because you should not avulse MCL. MCL. So I'll come back to that one. Can you see the posterior border is still not cut of the tibia? So I'm finishing with the completing with the saw. Quite a hard bone this is. So we have taken less tibia. As you can see in a conventional, probably I would have taken up to the defect. But here we are still there is some defect. Okay, no. Yeah. I'll just show you that. Yeah. As you can see, Nibbler. So this is a defect, medial defect. We have not taken up to that level. Conventional probably I would have taken up to that level. So there is bone preservation, bone conservation. Tibia, what was the size tibia? This is a 4. Okay. Finish there. There is still some osteophyte. We'll see. If I take that osteophyte now, probably it will affect the balance. So I will see the balance and if required, I'll probably take a little bit of it. Okay, next one. So femur is E femur, 4 tibia, open the cement as well. Pins out. And then so I'm taking a little bit of this with the saw itself, so we'll just see. If you're not being careful, you can damage the MCL. Someone still didn't answer that MCL question. You should not detach. We're not, as you can see, there is no release of soft tissue here, as you can see on the medial side. Everything is intact. That's the biggest advantage of it. Pins out. Pins out. Advantage of doing a robotic knee replacement. Up. We'll take remaining posterior osteophytes. Lift up. Space bar on. I think little posterior osteophytes will take that osteophytes out. Okay.
Nishikant, as far as that injury to the distal part of the MCL, suture augmentation is the best way, or in one time I used to use spiked washers which look like polo. You know, those peppermints which are mint with a hole. So they have got spikes, and so it's a spiked washer whereby at an angle you can put a screw. But suture augmentation will be still better when you are doing TKR.
Yes, sir. Thank you.
If the trial is ready.
Meniscus. Still remember meniscus is there. I'm just taking that one out. Okay. Good. As you can see, osteophyte. Okay. And I think that's the important part. As you can see, this corresponds very nicely. Whether can I say the side camera here? See, it fits very nicely into the plug holes, peg holes. So that means your rotation is what you planned. Okay, done. Clean swab. Okay. So we aimed for 9. That's 9 spacer. And now we'll check it. Okay. Now. So as you can see, the gaps are 12 and 13. And of course, varus is about 3 degrees. Limb flexion is 5 degrees. We consider the 0. Knee to knee. And in 90 degrees, 10 and 11. And 0 valgus varus. I think that's what we wanted. And clinically also you can see. Can you put aside? See, it is quite stable. Not moving much. You rotate, stable. That's what we want. I think that's end of the trial. We're going to cement it. So now we can have any questions.
Yes, sir. One question. Is angle blade plate better or a dynamic hip screw?
Sorry, go on.
Is angle blade plate is better or dynamic hip screw is better?
This is for the next session.
Next, yes.
What's your
I
next
think,
session? Okay, sir.
Dr. Dilip Shah is there. He's a big fan of hip fractures. He's going to explain in a minute. Probably, I think we have done this one. We're going to implant it. Probably we will have
Reddy sir, can I ask you a question?
Go on.
Dr. Dilip Shah here. Is the tourniquet continuously applied or you will do
Yes, it is applied. You can see tourniquet time.
Is it the demand for robotic surgery or we would prefer to do it only
I routinely use tourniquet. My tourniquet time most of the time is between 30 to 35 minutes. And with the robotic is 42 minutes. Now it's 42 minutes. It takes another 10 minutes. So less than 50 minutes. I wouldn't worry too much about tourniquet if it's less than 1 hour. Any quadriceps inhibition, feel if it is more than 50 minutes to 60 minutes.
And how's the patellar surface? How's the patellar surface? We didn't see. Are you going to?
No, I'm not done patella. Patella, I do not resurface it unless there's a problem with the patellar tracking. I do patelloplasty. Take the osteophytes out, expose the subchondral bone, and make sure the tracking is good.
Yes, sir. Dr. Balaji is asking how much effective is a robotic surgery in revision TKR for deficient collateral knees?
For revision TKR, I don't think there is no software there. Ravi, no software revision. There is no software or revision TKR. There is a software for unis, software for the hip replacement, but there is. So injection, I think I'll just show you. This is very, very important. We are doing a study with Australian team. Can you come this side? So the most important thing is we give U-shaped infiltration on the femur, proximal femur, in the periosteum, as you can see. Anteriorly, medially, and laterally, and posteriorly. Because most of the pain comes from the periosteum and here, not released much, so there's no point in giving much bed. But most of the time, these are the 4 spots we give local infiltration cocktail, modified Ranawat cocktail. We stopped putting steroid, but now we add small amount of steroid with Australian anesthetists. They showed steroid will reduce the amount of inflammatory markers and less pain. Small swab. Ready on that?
What is this steroid? Is it depomedrol?
Sorry? Kenacort.
Is it depomedrol?
No, it is Kenacort.
Kenacort.
Yeah.
Triamcinolone.
Yes, you're right. Can I have the gloves? The presentation ready on that? So now, probably after this, we will have Nishikant. We will have little presentation on all inside before we move the cameras to next theater for PFN, once we do cementing, this one is important. We stopped using clips for the skin. We use, what is that? V-lock, subcutaneous. So wound heals nicely and the pain of clips also not there. And more important, the thing is vancomycin wash. We keep washing before implantation with vancomycin. It has been showed to reduce the incidence of infection. Whiteside published a lot on vancomycin wash for the all implant surgeries. So that's a tibia. They wanted a gold knee. This is a opulent knee. But I don't see much difference in any of the implants. I keep saying to the patient that surgery is not implant based, it's technique based. Good surgery with an average implant will last long enough. Other day, someone was saying this opulent is for old people. I don't see any evidence in that. Lift up. Good. And you can see good quality bone, and as you can see, the cuts are very good with burr. As you can see, very precise. Cement.
Dr. Reddy, sir. Dr. Chandrasekhar here.
Yeah, go on.
So, what is your indication for stem, tibial stem?
Yeah, that's a good question. Yes. Whenever you use reconstructing bone defects with a bone graft or with wedges, you must use a stem. And osteoporotic, rheumatoid arthritis, where you suspect very weak tibia, stem, I would use a stem. But main indication is whenever you use bone graft or tibial wedges for reconstructing tibial defects. Same on the femoral side. But more often we use stems on the tibia than the femur. Okay, that looks good. Full extension clinically. So, okay. And as you can see, stable knee, clinically must always cross-check it clinical. 9 poly. Two-knee time is about 45 minutes now. So when we started, we used to take about 80 minutes, but now around 40 minutes. I was talking too much, so probably taken 5 minutes extra on that. And I might have seen, we do not sublux the tibia. That also reduces the pain, post-operative pain. If you sublux more number of times, it will cause more pain. So we do not sublux. Even for insertion, we make sure there is no cement on the back. Lift up, lift up. Back of the tibia. No cement. Okay, good. That's a poly. So without subluxation, we just insert inside and impact. Good. Soft tissues. Wait. There is soft tissue. Give me moments. Okay, good. So I should go with one hit of the hammer. So that's tibial insert inside. And yeah. So Ravi, you can descrub and get your presentation ready. This is the patella. As you can see, it's quite damaged. So we will take osteophytes. So can you have the camera on this one? Nibbler. So take all the osteophytes out. And I'll show you one trick in patella resurface and not resurfacing patelloplasty. We published a paper on circumcision with diathermy, with or without It was a thesis of Ravi Teja, and we found significant difference. So we circumcise, but we have to be careful not to go too deep. Otherwise, it will devascularize. Okay. And the tip is, that is the lateral part. So you take that lateral part off, and it will help you in tracking. Here is not much, but sometimes you see big osteophyte there. So just expose subchondral and make it smooth. And we check the patellar tracking. I think that looks good. That's good enough, I think. We'll just check once. Take it out. Without thumb. See, it should track well, as you can see, without any thumb. Can you see that? Yeah, okay, go on. So that's about it. Thank you very much. Now we're going to have the little presentation before we start off the... So cameras can go to the other side. One camera go to the other OT.
That was excellent.
Any questions on this?
That was excellent demonstration. Excellent. We never looked that. It looked so smooth. Everything went so smooth.
Thank you. Now I think that is the all inside ACL technique. I'll pass it on to Dr. Ravi Teja. Ravi.
So thank you, sir, Dr. Reddy, sir, and his team for the excellent demonstration for robotic knee replacement surgery. Now our second session will be on the ACL reconstruction tips and the tricks by Dr. Ravi Teja.
Yeah. While we're getting ready for the surgery, this is a little talk, I think. Take it
out. A question to Dr. Reddy.
Yeah.
Will you release the tunic and do hemostasis or?
Yeah, absolutely. Absolutely. I don't use a drain. So we release after bone cement setting, we release the tunicae, hemostasis and closure. It is important. It is important. We do not close without hemostasis and releasing of tunicae.
And
that's a very good question.
The tunicae preemptively on posterior medial side, will you cauterize so that
if any bleeding, we inject what is that? Tranexam into the joint. So no drain.
No drain. Tranexamic acid.
Yeah, tranexamic acid.
And intravenous also will you give now after release of tunicae?
Intravenous? No, we do not. Only intra-articular. 1 gram of tranexamic acid. Ravi, you can go ahead.
It is not flattery, Dr. Reddy, but it was wonderful show and excellent execution of a complicated surgery which looks so simple.
Thank you. Thank you. It's all, I think, your kindness, giving credit to, I think, for everyone, knee replacement is very straightforward, simple operation, provided it goes well. But if you get into trouble, like cutting MCL or too much of bone or balancing is not right, rectification is very difficult. So those who are starting early, those who are in a remote places must get good enough senior surgeon, good assistant. When you're doing surgeries, I think your assistant is equally important. You must have experienced assistant to do these surgeries.
You don't put any emphasis on the scanogram. I can see the scanogram behind you.
Yes, we do. Scanogram, yes. We do have a scanogram, but that is part of the CT scan. So we measure. Scanogram is done for all patients. Yes, it is because weight-bearing scanogram also we get a lot of information. But we don't plan based on the scanogram. We compare with the CT scan, which is supine one, because what is happening is we do not, it is not a conventional robotic one. What happens, it is on the table, we achieve the deformity correction and get the alignment on changing the position of the femur, positioning the tibia and the cuts. So scanogram probably not very important here, because it's dynamic balancing. Yes, I think Nishikant, you can go. invite Dr. Ravi Teja so that he can give his presentation.
Yes.
Ravi,
Okay, sir.
got
Sure.
it.
Can you hear us?
I'll see you shortly
Sir,
when we
we can
start the
hear
lecture.
you. Whoever is speaking, we can hear you.
Can you hear us from here?
Thank you.
I'm Dr. Ravi
Yes.
speaking.
Yeah, sir. Yes, sir.
Yes,
Go
yes.
on.
Okay, so we'll start the presentation. So I'm talking on all inside ACL fixation. Mute kar do mera. So as we know that ACL reconstruction, we have been seeing how it has been progressing over time. So we know the transtibial technique that we have been doing for some time. Now we are doing all inside ACL, wherein we are trying to preserve some bone and also making sure that it's double suspensory so that it's readjusted on both the sides to make the graft taut of whatever appropriate tension needed. So when it comes to double suspensory fixation, we use buttons on the tibia side. They are reverse tension devices. So on the femur side, we all know that we have Ultra button from Smith & Nephew. Then we have got graft link from Arthrex. So we try to tension it on the femur side to make sure that graft is taut. But the beauty with the double suspensory all inside ACL is that you have ABS implant.
So please check the audio.
We can't hear you, sir. We can't hear you. And besides the technical team, please, can we have Dr. Ravi to be seen?
Yes, the team is trying. Just a minute.
Sure. We'll be patiently waiting till it happens. Okay.
No?
Thank you.
Oh, can you hear me?
Yeah, sir.
Okay, sorry. I was just thinking that it was not audible. So yeah, we'll proceed. So yeah, as mentioned, with regards to the anatomical landmarks on tibia and femur, that we try to go medial to the lateral on of and anteron of lateral meniscus. That's where we take the tibial footprint. On the femur, we go on the anatomical footprint of the ACL. We know that there are two bundles for ACL. So with the all inside ACL, we have got an outside in jig, wherein we place it on the right anatomical landmark on the femur, and we go with the flip cutter. I'm sure you are aware of the flip
Sorry,
cutter.
Ravi, sir, your voice is not very clear. It should be loud.
Check now.
And you are not visible also.
Can you hear well now?
Now it is loud and clear.
Well.
Okay,
Loud
good.
and
Thank
clear,
you. Thank you.
but
Thank
we
you so
need to
much.
see you
So
on-
yeah, so as mentioning, I was just talking about the anatomical landmarks on tibia and femur. With regards to all inside ACL, we have got all inside jigs, wherein particularly we can try to go outside in using a flip cutter. So flip cutter is a kind of a device wherein we try to use it as a guide wire first, which goes in and tries to open to the respective diameter of the graft size, and we drill as much as whatever we need. Say for example, our graft length is 60 centimeters, and then we have got a diameter of 8 mm. So we kind of flip it to make sure that we drill 8 mm of diameter with the length of whatever is needed. We usually go 20 mm in the femur, 20 mm on the tibia, and we try to leave it around 25 to 30 in the joint. So which almost comes to around 60 mm, which is 6 centimeters. So then we have got the ABS device here, which is a reverse tension device. We mount it on the ABS button, and we shuttle it through the femur, flip it on the femur, and then we transportally we flip it on the tibia also. First we tension it on the femur side to engage 20 mm of cortex, and Later, we try to tension it on the tibia side, making sure that it is taut on both the sides. The indications of this double suspensory all inside ACL is that it can be used in both primary and revision scenarios, particularly in revision scenarios where you don't have adequate bone stock or your tunnels are quite dilated to put a screw in the conservative manner. So as mentioned, adequate femoral and tibial bone stock. Then a disadvantages being, I think, in patients who have got failed double suspensory fixation, I think it's important to consider those as contraindications. Advantages being minimally invasive, bone preserving, and results are as equal as traditional techniques. It's just the advantage of having double suspensory to make sure the tight graft is tensioned. And definitely, as mentioned, we are taking less bone, so it leads to bone preservation and less pain post-op. So a couple of case presentations wherein we tried to do the diagnostic arthroscopy. Then we drilled through the femur. This is our graft, around 9.5 centimeters, is a solid graft. Then we placed it on the tibia. Then we shuttled it through. You can see this is on the tibia, and the other picture is showing on the femur entry. And then you see the graft shuttled through and tensioned very well. And this is a post-op showing the graft link on femoral side and the ABS button on the tibial side. So studies also kind of showed that it is as similar to as button and screw fixation devices, low graft failure rates, and it can be used along with internal brace, which they kind of propose it as a seat belt to protect the graft. But again, there's no long-term study that proved the additional advantage of putting an internal brace with regular ACL. So I think that's it. I just wanted to bring this double suspensory all-in-dead fixation. In the meantime, we go through the next live surgery. I hope it was some takeaway for the viewers, and I'm happy to take any questions if you have.
So Ravi, I have a question for you. Can you hear me? I'm
Yes.
Vinay from Jaipur.
Yeah, I can hear you, please.
Yeah, okay. So, brilliant presentation regarding all inside. Now, do you do all inside? Is it your standard operation, or do you do it for selective cases to avoid graft related morbidity? Because you can just use a single graft, and because you need a short length, you can get away by just a semi-T rather than, when you do conventionally, you can take semi-T as well as gracilis.
Oh, cool. So firstly, let me kind of thank you. Probably, I think I didn't see that you're on the screen, but I have seen a lot of videos of yours before I did surgery. So I'm very excited to see you here. Thanks for this question. So I think, as you mentioned, my like when I was trained in Australia, Sydney with David Parker and Fritsch, they kind of clearly told me that your graft diameter should be more than 8. That is your first important thing. If I think the graft are thin and I don't think I'll be able to get more than 8, then I'll right away go to double suspensory fixation, compromising on the length rather than the graft diameter. But as you mentioned, if say for example a graft comes well and I think it is beyond 8, I can just go ahead with ultra button or any button fixation on the femur with screw on the tibia. Particularly in females, short notch, and I think probably in patients who I think come and ask us particularly that I want all inside ACL, but otherwise there's no additional advantage between an all inside versus button and screw fixation scientifically.
Thank you.
Sir, we have some question from the audience. Which is the best graft for the athletes?
Again, it depends on what kind of a person, how is his requirement. But if an athlete or high performing sports person, definitely I think BTB or quads are the graft of choice, and similarly revisions also. I think, but if it's a regular normal people, I think hamstring now peroneus longus is also catching up. So, but again, I think with peroneus longus we should be very much aware of any flat foot or any other contraindications particularly, but I think hamstring is a good graft for regular cases, and BTB and quad is graft of choice for high performing athletes or high demand people.
Sir, what fixation methods are we used for securing the ACL graft?
Can you come again?
What fixation methods we use for securing the ACL graft?
Single graft?
Yes.
See, I think again, as mentioned, my approach would be not whether it's a single graft, double graft. It is a diameter I'm very much inclined towards. If it is a single graft and we are not able to achieve beyond 8, then I would kind of again go for double suspensory with making sure that the graft diameter beyond 8 and the length can be reduced with double suspensory fixation. Sometimes, if even then it is very thin, then I would probably add it on with internal brace to protect it.
Okay, so the last question, what is the typical rehabilitation protocol following the ACL reconstruction?
My patients wearing next day and 0 to 90 allowed, unless if someone has a meniscal repair done. If there is a meniscal repair done, then I'll go with partial weight bearing for first 2 weeks, followed by full weight bearing. But I think next first weeks mainly focusing on range of motion extension, particularly without any lag, and then exercises, and then followed by training for the next 3 to 6 months.
Thank you. So can we now move ahead for our the second
thank
live
you. I
surgery?
mean, Professor KJ sir want to just thank for this opportunity. Just I would give the screen to him. Thanks once again.
Thank you, Ravi. That was a wonderful presentation. We keep doing quite a few of them. Thank you for all the moderators previous session. Dr. Dilip, my good friend, is still there. Dr. Chandrasekhar, Dr. Madan, and H.S. Gill, thank you very much for your moderation. Nishikant, you're doing a wonderful job. We are ready with the PFN.
Yeah.
So I'll just take you through the theaters just in a minute.
Yeah, so our now second surgery will be proximal femoral neck fixation of proximal femoral fracture by Dr. Shiva Reddy, Dr. Jairam Reddy from the Apollo Hospital, and Dr. Dilip Shah and Dr. Vinay Singh will be the moderator and the expert for the second surgery.
Okay.
Yes, sir. Dilip sir or Vinay sir, if you we have one question for the now second surgery. First question is what is the common indication for the internal fixation of femoral neck fracture? Common indications. Yes, Vinay sir or Dilip sir?
Okay, so common indications for femoral fractures are, basically you classify them into a stable fracture or unstable fracture. So for me, anything which is stable, my choice of implant is DHS. And for anything which is unstable, which I reckon is unstable, my choice of implant will be some form of a cephalomedullary device. And people keep on asking which is better. But I don't think there is any competition between two because the indications are for two different fractures. So for anything stable, I will go for DHS. Anything unstable, which is for PFN. So both stable and unstable pertocontric fractures are the common indications for fracture fixation in this area.
Okay, now we'll hand over to Jairam. Yeah, go on. Can you hear? Jairam, say hello.
Can I hear you? Hello?
Nishikant, can you hear Jairam?
Yes, sir. Yes, sir.
Yeah, go on. Go on.
And thank you, Vinay sir, for explaining that question.
24 years old lady with an intertrochanteric fracture.
Sir, audio is very low. We need mic.
Okay. Yeah, can you say? Sir, can you say?
Yes, now, sir.
Can you hear him now?
Yes, sir. Yes, sir. Yours
Ah,
is.
got. So just describe what you're doing.
The posterior border as well, anterior border as well here.
I think the audio is still very
Yeah.
low.
Very low.
We can barely hear anything.
Can we? But why it's not?
Mic.
Ah, okay. Okay. Can you say hello?
Hello, sir. Is it okay now?
Better than before.
Sir. Okay.
Can you increase the volume on that?
Still low though.
Is it low? Okay. Somebody can hold mic to him. Go. Yeah. Yeah. Go on. Yes.
Yeah. First, I will palpate for the anterior superior iliac spine here. Can you show me here? Here, now. And next, the trochanter, the tip of the trochanter, the posterior border as well as the anterior border. My incision is pretty straight forward, just proximal to the tip of the trochanter, about 2 inches.
Can you hear us?
Yes, sir.
Skin and subcutaneous tissue incise. Self-retaining, please. Mop. Self-retaining. Deep knife. Can someone hold it? Deep knife. Next, subcutaneous fat. Self-retaining, bigger one. Bigger one. Okay. Hold it. Deep knife. Next, I would like to see here the fascia or the gluteus. I can see here. Can you show me there? No, not possible. Okay. Yes, I incise the fascia of the gluteus. Once I incise the fascia of the gluteus. Bigger one. Just let me clear this one. Give me a deep knife. Deep knife. Yes. I will clear the muscles with the finger, just vertically along the line of incision. Once I clear it, I am able to feel the trochanter tip here. I would like to pass the bone awl, that is cannulated bone awl, so that we don't need to again and again find difficulty in passing the guide. Yes, now I am able to feel the trochanter tip here. Yes, now show me.
Over that side. Other side. Yes.
Yes. Shoot Siam. Can someone show the Siam there? The trochanter here, you can see it is being displaced, communicated. Siam. Shoot. Yes. Now you can see that bone awl at the tip of the trochanter. I am trying to manipulate that piece of the trochanter with the bone awl. Yes. Siam. Yeah. Yes. Lateral view. I would like to go with the lateral view. Yes. My entry is good. The lateral view as well. It is parallel to superior part of the neck of the femur as well. Yes.
Siam
So,
image needs to be seen. We can't see the Siam image.
sir.
Siam image of the lateral is not seen. Okay.
Yes, I want to change it little bit anterior. It's going posteriorly. Yes. Show it now. Yes, come to AP. AP. The lateral I am now satisfied with the entry. I just want to check it in the AP as well. Up. Yeah. Slightly medial it is. I will change it to a little bit lateral. Yes. 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 Now show Siam. Come to lateral. Yes. This is the entry into the lateral view. Looks good. Now I'll pass the guide wire. Guide wire, please. From the AP. APH. Guide wire. I'm passing my guide wire. Please can let it go out. Yes. Gone in. Show me Siam. Bonal out. Guide wire.
Hold the guide.
Yeah, Siam, but for the guide. Mop.
Yes, sir. We can
Yeah.
take one or two questions during the session also.
Okay,
So,
Siam.
sir, how do you assess the rotational alignment of the limb intraoperatively during
Come
the
to-
fixation? Sir, Vinay sir or Dilip sir?
Come to knee joint.
After
Hand
having
in.
seen the reduction,
Yes,
what
Dilip
you
sir.
need to see is from anterior superior iliac spine, it should show to the second toe if at all you have
Yes.
seen second toe is visible. And patella should point to the ceiling when you're
Lateral.
trying to introduce the nail. That should keep the alignment properly.
Lateral to the one. Lateral.
So from ASIS to middle
Nail.
of the knee to the second toe.
Reamer. మొత్తం full reamer. అది full. మొత్తం. Camel. Yes.
Okay, sir.
She had a total knee replacement 1 year back. Bilateral total knee replacement. You can see the implant there at the knee joint. So now I am planning to put a long proximal femoral nail because these days the long nails have a better outcomes than the short nails. Now I'll go with the reamer. This is 8 or 9. To check the diameter of the nail, I'll go with a reaming of the intramedullary canal. Yes, shoot down knee joint. Knee joint. Little bit down. nail. Okay. Yes.
Okay.
Sir, what count?
I didn't quite understand the logic of putting a long nail. You said nowadays it is. Why is it so?
Sir, yes, sir. There are a lot of publications nowadays, sir, which is showing that long nails have a more stable fixation than a short nails, which is going to fail in the due course of time, sir. Because of the fracture, maybe, and as well as the patient.
No, if it is subtrochanteric or that level, you definitely need a long nail. For a pure intertrochanteric fracture, it is not mandatory to use a long nail. But maybe it's your choice, so you can carry on.
So can I just input in this debate of long nail and short nail? I think I would agree that ideally, in every case, we should be using long nail because the curvature is the shorter nail is much straighter, and there is always a risk of stress riser because most of these fractures happen in osteoporotic males and females. So there is always a risk of peri-implant fracture because of stress riser. However, I do sometimes use short nail, especially in a very elderly patient who is medically sick and you want to do a quicker operation, and to save that some operative time, you use a shorter nail. But most times, my choice is also a long nail.
Even yesterday, I have a patient, sir, with a short PFN. He has just a trivial injury, which has got a peri-implant fracture in the distal run. Just not the patient is just age of about 45 years.
Yeah, because usually if you don't get your entry perfectly, it hinges on the anterior cortex, and that is it just breaks because of the repeated microtraumas. Sometimes you don't have to fall; it just breaks.
This is 10.
Yes, Dilip sir, you want to add something?
Yeah.
Now I would like to check the length of the nail.
Do the distal interlocking is very important. If you feel that it is not a stable construct, then you can leave it at a dynamic kind of a hole, and you do not make very solid kind of fixation by using two screws. Maybe one screw is good enough. If you are using a short nail. If you are using a long nail, then it's your choice. But then it does not mean that short nail is not good for intertrochanteric fractures.
Proximal hip joint.
Okay, so thank you, Vinay sir and Dilip sir, for explaining.
And second,
now I am measuring the length of the nail, sir, to put a long nail with a radiolucent scale.
And what's the diameter you are using?
I have rimmed for 10, sir. Now it's 36. 10, it's gone quite easily. I am going with, I will rim proximally with a proximal rimmer, and I will go with the 10 number nail, sir. 10 into 36. Proximal rimmer. Proximal rimmer. This
Sir,
is a proximal. Sir.
Okay. How to avoid varus malreduction during the femoral nailing?
We first we have to check the reduction, sir. Once the reduction is checked, we will see the alignment of the proximal fragment with the distal fragment. Most of the varus alignments will have a negative medial cortex, sir. That means the proximal fragment will go lateral to the distal fragment. In that way, we can assess the varus alignment most probably. But sometimes even after putting the nail also, the proximal fragment tends to go varus and valgusly because of instability maybe. At that time, we have to check before putting the screws proximally, sir. Then we have to correct it accordingly, whatever is being required. Yes. Yes. Yeah, proximally rimming is done with a proximal rimmer. Now I am going to put a nail of 10 into 38, 36.
36.
36, right side. This is the nail. This is the nail of 10 into 38 size.
36 or 38?
36, sorry. 36, sir. 135 degrees angle. Now I am checking the proximal screws. Is it free enough? Yes.
Sir,
Initially, we have to check pre-operatively outside only.
We have one more question. In osteoporotic bone, what additional precaution or modification do you take during the fixation?
Generally, in osteoporotic patients, sir, we need to put a screws along with that, the augmentation with the cement. Nail. Ram.
Yes, Vinay sir, if you want to add something.
Ram. No, this one.
I think most of these patients are seen in elderly patients, so they are mostly osteoporotic. So I won't take any extra precaution. I think the most precaution that you want to have is to have a good reduction. If you have a good reduction on both AP and lateral, that will be the key that will decide whether you're going to have a successful operation or not. Even if the bone quality is good, but your reduction is not great, specifically on the lateral, and then any amount of bone stock is not going to stop the implant from failing. So of course, there are times if you feel it's too osteoporotic, then you can augment with bone cement. But that's usually not necessary. I haven't done it ever in my lifetime, and I've not regretted it. But it's described, people use it. But if I have to give one key message, is perfect reduction or near anatomical reduction on both AP and lateral.
Dilip sir,
there cannot be question about not having a proper reduction. If it's not proper, it's going to fail. Any amount of augmentation with cement or anything is not going to work unless you have a proper reduction. And my normal practice is, if we have detected by doing a DEXA scan, from third day onwards, I start with injection teriparatide, which is given for minimum 6 months to 2 years.
Sir, you only give teriparatide or teriparatide with denosumab?
Teriparatide is good enough. If you give denosumab, it's good for first 6 months. Then you have to continue that also for at least 4 years. But teriparatide will do the job well.
Okay. Vinay sir?
The patient I cater, I rely on my reduction.
Knee joint.
My patients cannot afford teriparatide, but denosumab. But yes, if you have any doubts about it, if there's osteoporosis, then there's always advisable that if you can add these two, either one or in combination, it does help in fracture healing and also preventing further fractures.
Fine. A to B.
Yeah. So one question from Dr. Ravindra Patil. Any tips to avoid Z effect in the fixation?
Can go down still. Hammer. Yes, should.
Sir, one more question. Any tips to avoid Z effect in the fixation?
I don't think there is any specific tip to avoid, Z defect. Z effect. Z effect is effectively a sign of failure, and failure of any fixation could be due to multiple reasons. So you cannot just point it to one thing. But if you get a reduction right, if you have chosen a good implant, and if your screw size are good, then the chances of Z effect can be minimized. So, good reduction, good surgical technique is the only way. I don't think there's any specific tip for how to avoid the Z effect.
Yeah. I think about osteoporosis, Nishikant, you asked the right question. Can you hear me?
Yes, sir. Yes.
Surgery, we see a lot of people with osteoporosis. So we routinely put them on one of the, it's quite a few options available, teriparatides. Because what happens is fractures become very common and shrinkage of the prosthesis also become very common. So we routinely put them. The other reason what happens is most of the time it's senior surgeons who are demonstrating the surgical techniques. We have to develop next level of surgeons. That's the reason I put 2 young surgeons to demonstrate about trauma. Nishikant, I'm sure you understood.
Yes, sir. Yeah.
This is extremely commendable, to choose the young surgeons, and for young surgeons to take this on a live surgery. It requires a lot of guts. So I must congratulate you.
I know. That's the reason I think what happens is we have to develop next generation people to involve in teaching and training, because if we retire, there's nobody to take over. And
Absolutely, sir.
these are all my
Absolutely.
students. So I encourage them to do these kind of teaching, because teaching is the what is that bottom line for all of us. Unless we train properly our youngsters, there won't be anybody to look after us when we become old. And when we need somebody to treat us, I think these are the people. It's better to know people who trained us, who trained them. I think that's important. I still remember in UK, I was there about 14 years. There were one of the British surgeon. I asked him one of the parties, Christmas parties, why you are so interested in training me, giving this job in NHS as a consultant. We need somebody like you to look after us when we need orthopedic operations. That's what I think, that's the intention. So it is important. Training should be part of our routine practice. Yeah, Jairam, go on. What level? You can see on the Siam. I'm trying to pass the proximal screws.
Again, sir, the audio is not visible. Oh, sir, no, we cannot, hear the audio. It's very meek.
Now I am trying to pass the proximal screw, sir. Nail has been passed inside. 1036. I checked both proximally as well as distally. The length and everything was quite good.
Yeah, so Dr. Partha Pal has asked the question. How do you decide between using a short versus a long proximal femoral nail?
Come lateral. Lateral.
Vinay, sir.
As I said before, if you listen to me and if you follow, the current practice, you should always use a longer nail if the fracture is unstable. And I presume your indication is correct and you're using a nail for an unstable fracture. So if you ask me, always a longer nail. Occasionally, if the patient is very sick and you want a shorter operating time, you want to get quickly out of the theater, I would use a shorter nail.
Same guide. So AP. Now I have passed one guide wire, sir, distal one. Now I'll try to pass the second one. Second guide wire. Shoot AP. Okay. This is a little bit inferior. Just I'll check it out, whether I have space superiorly or not. Shoot.
Yeah, so Dilip, sir.
Now there is a lot of space superiorly, sir. Now I would like to take out the guide wires once and reposition my nail. Guide wire pike is inferior.
Yes, Nishikant, you were asking something?
Yes, sir. The next question is, what is your protocol for weight bearing or rehabilitation after the fixation in elderly patients?
Elderly does not mean that it is not porotic. I think it is porotic bones. We take it for granted. And if your reduction is good and bone quality is not very bad, then once you try to see the straight leg raising against gravity, and once the patient can do it, which in my patients it happens by around 48 hours, then they walk with a walker, and I see that they bear a weight of around 5 kilos on a weighing scale. The affected limb has to be put on the weighing scale, which shows around 5 to not more than 10 kilos. And that is how they progress. And then according to the pain, if they can bear with the pain, then they can gradually increase, but not more than 20 kilos of the weight.
Okay.
And check X-rays at the end of 15 days, 1.5 months, and 3 months. And full weight bearing is done at 3 months.
Thank you so much. Sir, one more question. We have a lot of questions from the audience. Sir, what is your indication of using a trochanteric stabilizing plate along with the proximal femoral nail?
Drill, guide wire.
I think a proximal femoral nail, the type which I use, is usually intertan type. And there is one advantage that here you are going to see 2 screws at different level, whereas in intertan it is only 1 level, which gives you compression at the time of surgery itself. So that's a good advantage. So in such cases, there is not much of a problem with my patients.
Next.
Coming to your question, come again. Nishika.
Now I have
Yes, sir.
The guide wire position looks good, both in AP and lateral.
Okay.
Vinay, would you be happy with that position?
I would be delighted.
Yeah. I prefer, I think, because now I don't do much of trauma. I don't do any trauma. I think
yes, shoot.
these guys are there. But I think I prefer little inferior.
Yes,
Inferior
shoot.
screw. Because
I would have accepted the first position as well, sir. I would not have
that's what
wasted
I
that
was,
5 minutes.
that's what I was telling him. But he want to be picture
Perfect. You want to young. One thing I learned in England was, they used to say the enemy of good result is perfection. So sometimes.
Yeah, absolutely.
Scale.
Yeah, go on.
But looks pretty good now.
Yeah. I think, Vinay, I'm sure you agree. We get so many of these things, especially in our medical car. We get about 20-25 fracture neck of femurs every week in a medical college where these two work, and we do so many surgeries, and significant number we do not see them again. We don't know whether they're happy, satisfied, or whether they've joined or not. The follow-up is not to get, because in a rural setup, very difficult to bring people back. If they're completely happy, they don't come back. If something goes wrong, probably they may not come back to you. They go elsewhere.
No, sir. My observation is very similar to you, but I would slightly disagree. If they're happy, then they never come. But if there's a problem, they do come to you, sir. The first time they will definitely come to you.
Probably they will come.
Yes,
but I think
they will come to you. But most happy patients, they don't turn up.
I strongly feel these fractures are undertreated and neglected, and results, I think we can improve a great if we have proper training of the surgeons who are dealing with these fractures.
Absolutely, sir. And I'm sure in England, we used to see only them we used to do DHS and we used to discharge them. We used to never see them back. Discharge back to GP.
I know. NHS, I'm sure you data a long time back, they used to die about 3 to 6 months, majority, whether you operate or don't operate, because of comorbid conditions. That looks good. Jairam. I think.
Yes.
And Dilip Shah also loves PFN.
Shoot.
He's, whenever we do live demonstration, he would like to moderate this session.
But my choice is little different. As I told you, I would prefer intertan type.
Right. Okay. The problem with intertan, Dilip, Smith and Nephew people discontinued in this area.
So
I don't know whether you get it.
Miraculous now, Miraculous and Merrill.
Right. Yes. I think probably we should. We do not have those implants yet. We are asking Merrill to supply for our hospital.
Merrill also has now gradually withdrawn. It's only Miraculous now.
Right. Okay. Because I think there is. I don't know whether it's a technical problem. They're not supplying. Smith and Nephew intertan was used to be good, but I think they discontinued completely.
They have stopped giving implants to us.
Yeah.
Sir, we have received
Yes.
3 more questions. Dr. Yogis is asking, is partial hip replacement is a good option for comminuted intertrochanteric fracture, or when it is used for IT fracture?
Yeah, I use quite routinely for people. If it is to see, the fracture is around the lesser trochanter, and elderly people, one-off operation. We call it trochanteric replacement. We use bipolar, but we have to be careful because if not stable, they dislocate.
Can I interrupt, sir? Can I interrupt, sir?
Yes, sir.
At this juncture, please tell everybody to release the traction.
Yeah, go on. Yes, they should release traction.
Screwdriver.
Release the traction?
Yes, sir.
Yeah, they are doing it.
And you should emphasize to all the listeners and viewers.
Yeah, absolutely. I think Dilip Shah made a very good point that you must release traction so that there is a compression.
Yes.
And whatever distraction you applied will get released and get compressed to the fracture site.
Right.
That's very important. A practical
Very important. Otherwise, you'll never get that compression. I call it as table on table.
Absolutely, yes. And I think I was listening that short nail, long nail, but I think routinely, if it is below lesser trochanter like this, I think we routinely use a long nail. It takes few minutes extra, but we feel more comfortable, and the failure rate is less with long nails.
Yes.
You agree with that, Vinay?
Spanner.
I would second
Vinay
that, sir.
agrees.
I
I
would
do not agree. I do not agree.
If it is a good quality bone and not too much of, see, technically all unstable fractures. There was a paper recently. The results are much superior if you get a near anatomical reduction and use a long PFN. People go mini exposure and reattach all the structures around and get near anatomical reduction. They have better results than without proper reduction. You agree with that, Vinay?
Yes, sir.
I agree with proper reduction, but unless it is subtrochanteric, I would not prefer to put a long nail, because you see the bones which I see, they are so much of bowing that your long nail may come out from medial side or it may come out from anterior side. So you have to be careful. If there is too much of bowing, you cannot put a long nail.
You have to be careful, but long nail is like a femoral nail. It is like a long recon nail.
Nails have right and left from side to side, but anterior bowing cannot be prevented.
I agree, sir. I think the only difficulty with long nail is that your entry point has to be very good. With shorter nails, even if entry point is slightly up or down, you will still get away. But for you to do a long nail, your entry point has to be near perfect.
Yes,
absolutely.
That's it. And secondly, Vinay sir, teriparatite is 2,800 rupees per month.
I know, sir. It's it's a huge amount of money for Rajasthani people.
What are you talking? Rajasthan mein itna paisa hai. And this is preventing a fracture on the other side, no sir?
I agree, sir. But due to these government schemes, even people are coming in Fortuner and they don't want to spend any money. They just want everything free under government scheme.
It's everywhere, Vinay. I think that's what
actually
they don't mind spending so much of money on investigation and traveling. They come far away places to here, but they don't want to spend money on too much of money on surgery.
No. You have to counsel them that if you don't do it, you will get fracture of the other side in next 6 months.
Yeah, you are right. I think you are right.
You have to counsel them properly.
Yeah,
I will try that, sir.
Take this.
Try it next time, and you will stop doing extra work of preventing or extra work of doing a surgery on the other side.
I will try that, sir, for sure.
Please. Or otherwise, I'll ask some company to give you free.
Yeah, I think Nishikant, I think almost they're doing a distal locking, nothing much to demonstrate. So we have some more time. We said MPFL, I think that's important. 5 minutes for that topic, or what time you want to close?
No, let's finish off so that by 4:20 we should get over, or 4:30.
And we must congratulate these young surgeons, Dr. Shiva and Dr. Jairam, for doing such an excellent surgery, live surgery, not surgery, and the live surgery where so many people are watching.
Thank you, sir. Thank you, sir.
Big applause to them.
Thank you very much, sir.
And to
This
you,
is,
sir,
I think, probably second live surgery for them. Is that right, Jairam?
Yes, sir.
Yeah. Second live surgery for them. I think as they do more, they are very good. Both of them are excellent in doing surgery, but difficult to communicate, talking. I'm probably I may not do as good surgery as I talk, but they are better surgeons. I think they should get skills of communication, because then only they can be good teachers.
So you are
Thank
in
you very
safe
much,
hands.
Jairam, and
Thank
you
you,
are in
Shiva.
safe hands,
You are
sir.
excellent.
Just in
And
case
we
you
have
break your femur,
5
you are in
minutes
safe hands.
on MPFL. Dr. Sridhar is going to present. If you stay on the board, Dilip and Vinay.
Yeah, thank you, Dr. Shiva Reddy and Jairam Reddy, for the clear and skillful demonstration of femoral neck fixation.
Yeah, thank you.
Yeah.
Sridhar, come quickly.
Up on mic.
Sir, one specific question to Dr. Vinay sir. Dr. Rishabh Tripathi is asking Vinay sir, your thought on loosening the traction before tightening of proximal screw?
Of the proximal screw.
Yeah.
I think I would see if my philosophy, I work slightly different. You know, you may think I think differently, but when I do my proximal femoral nail, I would reduce it. I'll put my nail and I would put both the screws in the head. And whether you relax the traction table on the table or not, eventually you are going to make it loose. And when the patient weight bears, whatever collapse needs to happen, it's going to happen. So it depends upon what you practice. I understand some surgeons will definitely release the traction so as to allow that collapse. I think it's just going to collapse anyways, when the patient will weight bear.
Yeah, thank you, sir. One last question for this session. Dr. Manish is asking where to keep a positive reduction versus neutral reduction. Yeah, Dilip sir.
Both are good. I mean, positive reduction is better, but then if you get anatomical reduction, is the best.
And also, not all negative reduction will lead to catastrophic failure. I think that is also a misconception. Yes, reduction should be neutral to positive, but I'm sure in time you will experience that there are occasions where you have got negative reduction, but still the fracture will heal. So it's not that if you have negative reduction, everything is going to fail. Try to have a positive or neutral reduction.
Thank you, sir.
The negative reduction was in one time known as vein county reduction. So that's also not so good, but then you try to be on normal anatomical. If you want to err, then you can err on positive, but do not try to be on the negative so that someone can comment that this is not done properly.
Agreed, sir.
And regarding your point of not releasing the traction, once you have put the screws and once the patient starts weight bearing, the screws may come out by 5 to 10 millimeters, which is not a good thing on X-ray later on. So if you have on the day one exact placement of the screw with proper compression, then it should not have much of a problem.
Yeah, so we have received a lot of questions, and currently 1,857 live audience has currently watching this surgery.
So the number of questions were very less.
No, sir, there are a lot of questions. I compiled it.
So you are filtering them.
Yeah, I'm filtering out. Yes.
So the ones you can answer, you don't ask.
Yes, sir. Dr. Akhil is asking, will a slightly medial entry just brushing the GT avoid the wedge effect, and it is necessary to do so?
I would have told you that, but I didn't want to kind of harass the surgeon. A little more medial entry would have been my liking.
Usually it helps in getting the valgus. So sometimes, you can go slightly medial.
Because the young surgeon would have felt that after I have introduced, the moderator is telling me to put it more medially, but it would have been little better. But it doesn't mean that you should always try for that. And I use a honeycomb. Actually, once you have got a fairly good guide wire, if you want to go medially 2 to 3 millimeters or anteriorly or posteriorly or laterally, you can do by a honeycomb, which people may not be knowing. For your information, the guide wire which has been passed is passed into the hole. And then if you want to put it medially, then there are 6 holes which can make it medial, lateral, anterior, posterior.
I think I keep medial entry only in which, despite trying everything, I feel it's still in slight varus. To add that valgus, you can go medial. Otherwise, most of the smarter systems are trochanteric entry nails, so you don't necessarily need to go medial all the time.
Okay, Nishikant, if no questions, probably we can do this little on MPFL.
Yeah, now, yes, sir. So thank you, sir, for correctly explaining all the questions and taking our second surgery session. Thank you, Dr. Shiva Reddy, Dr. Jayaram Reddy, Thank you to Dr. Dilip sir, uh,
Vinay,
for
sir.
Vinay sir also for correctly explaining all the questions we have received during the session. Now our last session will be on the
MPFL.
MPFL reconstruction surgery by Dr. Sridhar Reddy. Yeah, sir, Dr. Sridhar Reddy, if you are ready, now we can.
Yeah, thank you, Alcom, for giving me the opportunity to speak, and Dr. KJ Reddy, sir, for the opportunity. Good evening, Dr. Dilip, sir, and Dr. Vinay, sir.
Right.
We were your students, and now we are just moving into the next step. So this is a 28-year-old male with a history of recurrent patellar dislocation. He had 4 episodes. The recent episode was 2 months back. He had history clinically on, there was a patellar glide of more than 3 quadrants. Patellar inclination angle was higher. The Brighton score was about 4/9. And on the MRI, we can see that he had an isolated MPFL tear and mild bone bruise on the lateral femoral condyle. So now we are switching. This is a real-life surgery. The surgery was performed today. We are just going on to the real-life part. So we had checked for the patellar tracking. There was lateral patellar tracking, and there was patellar glide, which was more than 3 quadrants under anesthesia. So we are now doing the gracilis graft harvest for the MPFL reconstruction. The plan is for a single bundle MPFL reconstruction. So as you can see, we have got the gracilis tendon out, and we have gone ahead with the preparation. Next, we are moving on to the surgical video. So we have done a bony landmark marking on the patella, the medial part, the medial epicondyle, the adductor tubercles. Gone ahead with exposing on the middle side of the patella. So as you can see, we are demarcating the layers on the middle side of the knee. So as you know, the MPFL is in between the layer 2 and 3. So we are exposing layer 2 and 3 going forward and getting a dissector onto the layer 2 and 3. So this artery forceps going under that layer will extend onto the medial side, and we get our medial incision near close to the epicondyle. So we can see that pocket being created between layer 2, 3. So traditionally, we can see that there are a lot of techniques of doing an MPFL reconstruction. Previously, we used to do just a lateral release. Then we had moved on to using suture anchors. The technique that we did today was a pull out through and through. We get the tendon through the patella and fix using a single interference screw fixation on the femur. So moving ahead. After opening on the medial side, we are passing the guide wires on the patella. So we demarcate on the patella surface a junction at the 2/3, 1/3 junction and pass 2 transverse guide wires. So as you can see, these guide pins are going on the upper third, middle third patella at the junction of the 2/3, 1/3 junction, through and through. A distance about 8 to 10 mm is maintained between the 2 guide pins. So after passing these guide pins, we then check on the CM to see whether they are transverse, going through and through, and confirmed with the CM guidance. Now we are doing a 4.5 drill through and through the patella. So this is the check under the CM. You can see that they are going exactly as we planned, transverse and on the patella surface at a junction from the upper 2/3 to the lower 1/3. So we backtrack, the graft is prepared on the background and we are shuttling it through the guide pins that are inserted. First on the upper one, we shuttle it. So these guide pins are inserted in opposite directions so that we shuttle the graft through and through. We give a small nick on the lateral side so that we can see the graft is opposed as close to the patella as possible to prevent any hardware or ethibond or any graft prominence on the lateral side. So you can see that we are putting a shuttle wire, the graft passing in. The graft end should be smoothly trimmed for smooth passage of the graft. This is one initial tip and trick. Now it is tunneled back into the second tunnel that is being created. So the work on the lateral side is to oppose the graft as close to the patella as possible. So this technique that we are using is to avoid the usage of suture anchors. As we had a good graft length initially after the harvesting of the gracilis, so we are going forward with this technique. So now you can see both ends are clear on the medial side. They're smoothly shuttling appropriately in the tunnels that we have drilled and the opening on the medial side. So now we create a shuttle so as to pass these graft ends onto the medial point. So second will be a dissection on the medial side between the adductor tubercle and the medial epicondyle. We have to identify the shuttle's point. So the shuttle's point is the line on the posterior border of the femoral condyle and two perpendiculars that are drawn at the end of the Blumensaat line and the end of the medial condyle. So an intersection point of about 8 mm circle could be drawn around that area, and we aim to fix that as the isometric point for the MPFL. So the femoral insertion of the MPFL on the shuttle's point, anatomically we are been checking on the CM. So you can see that the small circle, we have an Arthrex guide also to check for the shuttle's point. After confirming under CM, we drill once with the 4.5 guide wire. Second, the graft ends were about 6 mm. So we are aiming to put a 7 mm screw. So measuring the length and the amount of graft that will be filled inside the tunnel on the femoral side. We are putting a Athlon shuttle wire to shuttle them between the layer 2, 3, pull them on the medial side. Now the guide wire is pinned through and through, exiting on the lateral side. So this step where we are shuttling the graft through the designated tunnel that we have created. The smooth passage of the graft is paramount for a good fixation. So this isometric point has to be checked through the range of motion, and MPFL is ideally fixed with an interference screw at around 30 degree of flexion. So a lot of books say 30 to 45. We are maintaining about 30 degree flexion and fixing it with the interference screw, a 7 mm interference screw. You can see the graft well opposed in the layers 2, 3. So that is the graft visualization on the patella. It is secure, firm, smoothly going through a range of motion at the isometric point. So after fixing that, we check on the range of motion and close on both sides. We close the layers on the middle side. So this patient had a normal patella and trochlear groove was deep. So it was a type A trochlea. So we didn't have to do any other realignment procedures like TT osteotomy or a tracheoplasty. So we can see the patella is not moving. There is optimum glide about less than 2 quadrants, and there is no lateral translation of the patella. The MPFL reconstruction. So why instability? It's a multifactorial problem associated with more about limb alignment, osseous architecture around the patella, with the dynamic interplay of static and dynamic restraints. The passive stabilizers are the trochlear groove, the MPFL ligament itself, and then dynamically the quadriceps and lateral structures are involved. So the primary instability factors are a patella alta, more patella tilt, increased TTTG distance. So tibial tuberosity, trochlear groove distance quantified on the CT scan, and as secondary instability factors are the miserable malalignment like excessive femoral anteversion, a genu valgum, and an external tibial torsion. So clinically, we have to examine for apprehension test, a J sign, like we have seen in the previous video, a patella alta, patella tilt and glide sign, and check for also the Beighton score. Patella height measured on the lateral X-rays, a Caton Deschamps is more significant for us in this index, which is the diameter on the patella surface to the anterior tuberosity on the tibia. So trochlear dysplasia has to be ruled out. So B and D types require trochleoplasty, where you can see the crossing sign, a flat trochlea and a cliff-like trochlea, which need reshaping or a sulcus deepening trochleoplasty. CT scan needs to be done to assess for the TTTG distance, MRI to assess for the further structures. So primary patellar dislocation, 1 episode, we try to immobilize with a brace, a patellar locking brace. This is to prevent recurrence and start them on physiotherapy with quadriceps and closed chain exercises. In case of redislocation, more than or equal to 2 episodes, we go for an operative treatment. So this is the flow chart based on the de Jong classification of objective patellar dislocation, that any tilt more than 20 degree, we can go with a MPFL reconstruction. But with TTDG more than 20, we have to go for bony procedures like realignment and TT medializations. So our procedure was to go forward with MPFL reconstruction. The graft of choice was a gracilis. So you can see that the clinically we have got secure fixation, and patella was gliding smoothly at the isometric point through range of motion. So these are the intraoperative steps that we have showed: the Shortle's point, the isometric point at the MPFL, the fixation and the graft tautness. So determine appropriate graft diameter for smooth passage of graft, reconfirm the isometric point and optimum fixation of the MPFL at 30 to 45 degrees of flexion, and smooth patellar tracking with medialization of the patella with no lateral translation has to be mentioned. So this is the flow chart that all lateral patellar tilts can be done with an MPFL reconstruction, where that is are most of the common cases with no gross anatomical abnormalities. Thank you, sir. If there are any questions, I would like to take, sir.
Yeah, one question. In the patient of severe trochlear dysplasia, how to decide between isolated MPFL reconstruction and combined tracheoplasty procedures? In the patient of severe trochlear dysplasia. Sir, Dilip sir or Vinay sir.
You understand the question?
Yes, sir. So I got a question. So based on de Jong classification of types B and D, sir. So if it's like a cliff-like trochlea or a flat trochlea, we initially go forward with the types. So even if it's a shallow trochlea, we can escape with an MPFL reconstruction. But when these are flat or cliff-like on the middle side, our MPFL reconstruction is bound to fail in the initial surgery. So we will go forward with a trochleoplasty, with a sulcus deepening trochleoplasty. So these will involve us to open on the femoral side, create grooves medially, and use suture locking anchors that we have with Arthrex to get a sulcus deepening trochleoplasty done. And then we move forward with the MPFL reconstruction.
So one last question for this session, sir. How to manage a chronic patellar instability with multidirectional laxity?
Can I get the question again, sir?
Yeah, I think what happens is the one we showed was a simple traumatic, post-traumatic. So the trochlear groove was reasonable, patellar tracking was reasonable before the injury, but the MPFL was torn. So we repaired that one. But majority of the cases, recurrent dislocation, it may be congenital or various reasons, or patella altar, or very shallow groove. You need additional procedures in addition to MPFL reconstruction. So the question was multi-directional instability. We have to be very careful. Single procedure alone will not prevent further dislocation.
Yeah, thank you, sir. Thanks, Dr. Sridhar Reddy, for the session of MPFL reconstruction. Now, any last note if you want to add, sir, Dr. Reddy, sir?
I think we enjoyed this wonderful session. I think when the team was engaged, I think Allchem team worked very hard. I think they've been repeatedly calling me about the program and everything. As you know, live surgery is always difficult because the various technical problems of patients, getting patients for live surgeries. But I hope you enjoyed. We met your expectations.
Yes, sir.
And great discussion because end of the day, it's the moderators that make all the difference. The communication, discussion, and I think both in this session, Dr. Dilip Shah and Vinay, you were remarkable in answering and generating discussion, which is important because there's no point in just going on operating without discussion. So it was a great session, great moderators. I think Nishikant, I didn't recognize your talent, so talented. I think some of the questions were really very remarkable. Thank you very much for the entire session. I hope you enjoyed and hoping to see you sometime in future.
Okay. Thank you, sir.
Thank you very much. Now we'll leave this meeting, right? Thank you.
Thank you so much. Thank you. Bye-bye.
Thank you all the participants also for their active participation during our workshop. I special thanks to Dr. KJ Reddy and the Apollo Hospital team for their excellent live surgery demonstration. I also like to thank our moderator, Dr. Vinay sir, Dr. Dilip sir, for their valuable guidance throughout the workshop. We have received almost more than 100 of questions and 1,875 live audience currently is watching the session. I also like to thank our Allchem team, Mr. Chetan, Shailendra, for their support. Thank you once again and look forward for your participation in our future events also. Thank you all and
Thank you. Have a great weekend.
Yes, sir. Great weekend. Thank you, sir.